All right. Hi, everyone. Welcome to today's Savor Methods session in partnership with America's Poison Centers. We're very excited today to be joined by um, Dr. Chris Johnson O'Leary. She's the epidemiologist at America's Poison Centers, and Dr. Rita Farah. She's an assistant professor. So today's session is an exciting joint venture with the Poison Centers. As we know, key public health data sets are being reduced or discontinued, and injury researchers may face growing gaps in timely, actionable data. The Poison Centers offer a robust and underutilized resource to help address these challenges. We're really excited that they could join us today and tell us all about what they're doing in the space of data collection and access. So, thank you so much, Chris and Rita, for joining us. The session today is recorded. It'll be made available online later for members. And I will also we want this to be like a classroom setting. Feel free to use the chat, introduce yourself, say who you are, where you're from. Sarah and I will be in the background looking for questions that pop up. We'll let Chris and Rita present, but they're also open to having questions during the presentation. So feel free to pop them in the chat or raise your hand. We can help manage that. If not, I'll come on at the end and we'll do Q&A. All right. So good to see you. And thank you, Chris and Rita. And I will turn it over.
Course, I lost my unmute as soon as you stopped talking. Good afternoon, everyone. Thank you so much for having us present today. Again, I'm Chris Johnson O'Leary. I'm the epidemiologist with America's Poison Centers. And today I'll be talking about how poison center data can strengthen injury surveillance, particularly by filling the gaps that Kristen chatted about. We'll also talk about how poison centers can serve not only as data sources, but also as research and public health partners that can provide clinical insight and real world context. I hope you leave with two key takeaways here. First, a better understanding of what poison center data are, how they're collected, and how researchers and public health practitioners can access and use them. Second, I want to highlight how partnerships with poison centers can enhance that injury research through near real-time surveillance data and including clinical information and subject matter expertise in addition to the data themselves. America's Poison Centers is the association that represents the 53 poison centers throughout the United States, which serve all of the states and territories. Collectively, poison centers provide expert information and treatment advice 24 hours a day, 365 days a year, or 366 every day of the year, in 161 languages through our language line. Every case managed by Poison Center is then uploaded into the National Poison Data System, or NPDS, in near real time, approximately every 5 minutes, so very close to real time. What makes these data especially valuable for injury surveillance is the combination of national coverage, highly granular exposure data, geographic information, product-specific details, and clinical follow-up information. So whenever possible, specialists in poison information who manage the cases through the poison centers do follow cases up to a known conclusion as much as is feasible. Unlike many data sets that capture only severe outcomes or healthcare encounters, these poison center data capture the earlier stages of exposure and injury events as they unfold from exposure to referral to healthcare to a known conclusion of that healthcare. And poison center data may often be thought of as overdose data, but the scope is far broader than that. The data include unintentional injuries as well as intentional use, misuse, abuse, therapeutic errors, adverse effects, self-harm even, and environmental exposures. Beyond those reasons for exposure, they also span a range of substances and products. So people do typically think of drugs, that's over-the-counter prescription, as well as illicit substances and adulterated substances, but also consumer products like household cleaners, cosmetics, toys, button batteries, batteries in general, and chemicals, as well as bites, stings, and envenomation. So these are snake bites, spider bites, insect stings, scorpion envenomations, etc. All can be managed by poison center staff as well. Again, poison centers also capture that pre-healthcare and healthcare associated information, meaning that researchers can observe events well before they appear in claims data or in hospital discharge data or even mortality data sets. Speaking of the latter, this figure demonstrates one example of how NPDS, the surveillance value of NPDS data. This graph shows that more serious fentanyl-related poison center exposures were highly correlated with later fentanyl mortality trends reported via CDC Wonder. This illustrates an important concept for injury surveillance researchers. Poison center data can function as an early indicator system. Because the data are collected in near real time and include clinical severity information, they can help identify emerging threats sooner than systems dependent on those finalized mortality data or on administrative conclusions. The National Poison Data System currently contains over 85 million human exposure cases, with about 2 million exposure cases managed and added into NPDS annually. I already mentioned that they're uploaded about every 5 minutes, and surveillance algorithms also run continuously throughout the incoming data to be able to detect incoming threats in real time. So this monitors changes in case volume, clusters of clinical effects, geographic patterns, and over 200 definitions of incidents of public health significance. Or it has detected over 200 machine-generated anomalies, I should say, of public to be reviewed for public health significance. NPDS also supports surveillance activities for organizations like the CDC, FDA, health departments, academia, and other public health entities. And for researchers, one of those biggest strengths is that timeliness and the level of clinical detail, because the folks who are managing cases are highly trained. They're doctors, nurses, pharmacists who have received extensive training in toxicology, and oftentimes, and most of whom have already sat for the certification exam to be certified in specialists in poison information. Many traditional data sets provide scale of that magnitude, but without context, or context without timeliness, whereas NPDS provides both. Now, at the national level, the American Poison Center Toxicosurveillance Team reviews anomalies that are identified within NPDS based off of spikes in exposures, unusual clinical effects, or high priority events like botulism or potential chemical threats. The Toxicosurveillance teams works directly with the poison centers to determine whether those signals that come to their attention represent true public health concerns, and then coordinates with CDC whenever that is appropriate. So that creates a national infrastructure for rapid situational awareness and response. For injury researchers, that means poison center data are not just passive records. They're actively monitored, interpreted, and contextualized by clinical experts in real time whenever they arise to the level of an anomaly or fatality. But I'll come to that in a second. We also have internal dashboards serve as our surveillance tools that can be used within the network. The outbreak dashboard itself allows rapid visualization of increases in exposures by geography, time frame, exposure category, and percent change relative to historical baselines going back as much as 4 years. Not every important trend does produce a formal anomaly alert, so it's really helpful to be able to look at these dashboards and kind of see the things that wouldn't necessarily trigger the anomaly but could be interesting, whether it's gradual increases or localized patterns that might need a little bit more digging or prevention efforts. And so this is what our dashboard looked like in the beginning of this month. You'll see that there's a lot of some allergy meds, a lot of things with plants, stings, and also the normal things that you see in springtime because people are gardening, bugs are coming out. So it's really helpful to be able to look at this and say, hey, these are things that we expect to see. It makes sense that we're seeing an increase, but if there's a notable increase, we can also put out some messaging via social media, or if it rises to that occasion, put out a health alert about a certain substance. And this is a great way to have an at a glance that doesn't, for those things that don't rise to anomaly occasion, but might not also be something that we're actively tracking all the time. Poison center data also support pharmacovigilance and public health. So through pharmacovigilance, they can help identify emerging products or emerging trends, monitor adverse effects, detect misuse patterns, and observe formulation changes, particularly those that might be a quality concern that could be creating those adverse effects, oftentimes leading to a recall or coordination with our federal partners. In public health and injury prevention, they can help identify high-risk populations, track emerging injury patterns, support targeted prevention campaigns, and inform outbreak response. One of the key strengths of poison center data is that they combine that clinical information and relevance with that speed that I can keep talking about. Oh, sorry. I was supposed to have water beads here as well. So pharmacovigilance goes along with diphenhydramine and public health around water beads. So again, not just doing drug things, we also do have consumer products, with water beads being one of those consumer products that we often see show up in our data. Another important point for researchers is around data quality. So poison center data undergo quality assurance at multiple levels. At the poison center level, cases are reviewed within those poison centers under the oversight of clinical medical directors. And nationally, America's Poison Center supports standardized training, data quality review, and the data quality trainings coordinated and created by our data quality committee and the fatality review team. The fatality review team evaluates poison center fatalities to determine the degree to which an exposure contributed to a death. And there's also a pediatric subgroup, which focuses specifically on those pediatric fatalities. So this level of clinical review adds that important clinical interpretive context that might be absent from things like claims set data sets, other administrative data sets. Another modernization effort that we've put into place is around verbatim substance surveillance. So traditionally, surveillance systems depend heavily on those predefined coding structures, which is what the backbone of NPDS is. But emerging products often appear before that formal coding exists or before a product code is created to be able to track those. So verbatim surveillance captures exactly what callers report, I should say the case patient reports, because poison centers, while they do manage many of their cases via phone, there's also the opportunity for many poison centers to manage via text or web chat. So in any case, the verbatim substance captures exactly what the case patient reports, allowing identification of novel substances and products earlier. So for products like diamond shrooms, if you'll recall that from a couple of years ago, and 7-hydroxymetragynine or 7-OH products, those were and can be helpful in those types of scenarios. Potential patterns of interest can then be analyzed across different timeframes and linked to clinical effects and outcomes. So for researchers studying emerging substances, that again creates opportunities for earlier detection and then characterization of those emerging issues. Additional modernization efforts are focused on interoperability and analytic capacity. NPDS is transitioning towards MEDRA standardization, which improves consistency across data sets and enhances our opportunities for linkage with other surveillance systems or surveillance data. Whiskers we're actually going to be integrating a portion of poison center data into Whiskers in the coming year to strengthen their injury surveillance, largely because they have lost some of their other data sources. And at the same time, America's Poison Centers is going to continue to expand the AI-supported surveillance tools and enhanced anomaly detection capabilities. So those efforts are intended to continue to improve our early signal detection, the opportunities for data harmonization, and actionable public health intelligence in a time when mitigations can actually be put into place. Now I will pass it to Dr. Rita Farah to discuss how poison centers sit at the intersection of clinical care, public health surveillance, and research. Rita?
Hey, thank you, Chris. Hi, everyone. Thank you for having me. I'm gonna take you on a snapshot of what we do at the Poison Center. I'm an epidemiologist. I'm faculty with the School of Medicine at the University of Virginia, in beautiful Charlottesville. I'm also the lead epidemiologist at UVA Student Health. Um, our Poison Center, and we have a medical toxicology division, and we have a fellowship. We have a 2 years program fellowship in medical toxicology. So we are 5 faculty, 4 medical toxicologists and myself. We have 4 fellows, 2 first-year fellows, 2 second-year fellows. And we have 13 poison centers for specialists in spoon poison information at the Blue Ridge Poison Center. Um, Forgot what I wanted to say. So we cover half of the state of Virginia, and we offer services and consults to 74 hospitals. In this setting, having the medical toxicology division, the poison center, but also the analytical capabilities, we have an excellent toxicology lab led by Dr. Bazidlo, where we are able to send human samples and products to be tested, and we are able to detect what's in these samples, the human samples and products. And this is how we've been so far successful in detecting emerging and re-emerging substances. But more to talk about that through our publication and our collaboration. Next, Chris, thank you. So this is one of the papers I like the most, and the ideas sometimes come just from discussing cases in the morning or around the lunch. I remember like one of the medical toxicologists on the team, he has more than 15 years of experience. He was saying, aren't cases we're managing becoming more complex? I said, all right, let's look. How did the severity of cases Poison Center are managing change during the years? So I went to NPDS, our National Poison Data System, and looked at the past 15 years by adults versus pediatric, intentional versus unintentional exposures. And the numbers do speak. We see like between 2017 and 18, there is quite a spike, an increase in severity. So what we're seeing in practice can be translated into numbers. And this comes into play for the importance of the role of poison centers and America's Poison Center. A first layer of the importance of poison centers is how many cases do you manage per year, right? If it's 10,000, it's different than 50,000 or a million case. But the number is one layer, but there is also the complexity. It's different level of complexity if to manage a case, one call to the poison center and one consult to one of our medical toxicologists is enough, or we'll have to manage manage the case for 5 days and have 3-4 consults to the medical toxicologist. So it's still one case, but it's more effort put into the case. And I like this study because it showed the complexity of the cases Poison Center are dealing with, and it shows the importance of having medical toxicologists equipped and poison centers staffed with specialists in poison information and medical toxicologists. Next, I think this is also, so we looked at the data from different layers, right? It's what level of care did they receive, what were the symptoms, and what were the substances. Just to start with a general overview of the role of poison center. Next, Chris. Okay. This is the study we looked just after COVID. ended, we said, all right, let's look at the suspected suicide attempts in the teenagers during the COVID pandemic. And this is a repetition or an extension of a study we had done, my colleagues, before I joined UVA. My colleague looked at the suspected suicide attempts in teenagers by self-poisoning for the 5 previous years. And there was an increase. So we said, all right, let's see, COVID was such a unique pandemic or unique situation. How did suicide or suspected suicide change during or were affected during this period? If you look at the age group 10 to 12, and this work was published in the Morbidity and Mortality Weekly Report, the CDC journal, which get disseminated. And this is the importance, I think, to publish our work in very well disseminated journals so we can reach the bigger number possible of healthcare providers and public health professionals. So if you see the age of 10, 12, that was the most surprising. If you see the increase, like before the pandemic, compared to 2021, there was like a 70% increase in the number and the rate of suspected suicide, which was huge. The 13, 15, and 16, 19, still there was an increase, but this is the 10, 12 age group is a group that maybe doesn't come first to your mind as affected by suspected suicide attempts. And obviously, females were more affected than males in this during the pandemic. The next normal question was, what were the substances the most frequently involved in the suspected suicide attempts? And as you see, ibuprofen is increasing, but then during 2021, acetaminophen just surpassed ibuprofen with a huge share of suspected suicide. And we do worry about acetaminophen, first because it's widely available in big bottles of 500 tablets, and because its toxicity doesn't have a specific toxidrome, so we can act quickly. It's not like the opioids. And once the damage is done, there is high risk for hepatic failure and then death. And the number 5 that was starting to rise to the top number 5 was diphenhydramine. And the same problem of the high availability with high number of tablets available in one bottle. You can buy a bottle of 500 tablets of diphenhydramine easily everywhere. So to compare our data with other countries' data, where acetaminophen is not available in large quantities, so they limit the number of quantities, but also drugs are packed in blister packs. So, and studies show that removing tablets from blisters is less appealing in a moment of a suspected suicide attempt than having a bulk of pills that a person could ingest. So this was an attempt of us to highlighting what are the most frequent substances involved in the suspected suicide and where could the problem be. It was interesting to see also how the curve changed during the pandemic. If you look at figure 2, and you would see that between March 2020 and like June or May 2020, there was a decrease in cases. So when the lockdown was enforced and students were sent home, there was actually a decrease in the cases. So we thought, is there a seasonality in suicidal attempts? Apparently there was. Literature shows that. And the 2019 data just before the pandemic showed the seasonality of suicide. So it shows that during breaks like June to August, at the end of December, when the kids or the teenagers or children are home, the number of suicide cases decrease. But this was not the case in 2020. So it mimicked the stay-at-home orders, and between March and June, there was a decrease that was not similar to other years, but mimicked when people are at their homes. But after these 3 months, there was a high spike and increase in suicidal cases that overpassed the 2019. So it kept going on until October. So it's kind of to confirm our it confirms our theory of the seasonality, or what is already known about the seasonality of suicide. Next. Our next study was on psilocybin. At that time, always using the National Poison Data System. So hallucinogenic mushrooms and gummies, at the time we thought about the studies, were more and more available. And just to mention that we are in a college town, so we have the hospital, UVA University with 27,000 of students, and we have a lot of vape shops around the campus. So we are always doing a surveillance on what's on the market, what's are on these vape shops, and it coincides with an increase of the calls we're receiving at the Poison Center. So we've seen an increase of mushroom gummies coming to the Poison Center. And at that time, we did not have a unique code to separate the plant, the mushroom, from the gummies, the processed gummies containing psilocybin, the hallucinogenic agent. So we looked at the data, and we looked at teenagers and young adults. So we looked at the National Poison Data System for the cases of psilocybin related cases between these age group 13 to 25. And so as you could see on the first two graphs, you have the adolescents and the young adults. The increase in the number of cases is visible, right? So between 2018, 2019, and 2022, there is a huge spike. So I remember the reviewers challenged us, and there is many limitations to the National Poison Data System that we have, and we make every effort to mention the papers. So one of the reviewers said, yes, there is an increase, but what if your total number of calls increased? So this is where we added, and you see in shades, in gray shades, the total number of cases, just to say for this age group, the total number of cases did not increase to explain this increase of cases. And this is a classical presentation. Whenever there is an emergent or re-emergent substance, you see this huge increase because healthcare providers are not familiar with the presentation, like what the patients say they took and the presentation do not fit. They are more prone to consult with us to see, hey, what could be the best management for these cases? So I always trust an increase in the cases, but I'm careful interpreting a decrease in the number of reported cases to the Poison Center, because at some point that could be a decrease in exposures, but also it could be at some point healthcare providers are comfortable managing these cases, so they are less prone to call the Poison Center. And as you can see, and we mentioned in the study that we did not assess the impact of decriminalization of psilocybin, because the more the product is available, the more you're gonna get cases, especially in the pediatric population and teenagers. So we did state that we did not assess state by state or city by city to assess the impact of decriminalization of substances. But even in states that decriminalize, these products should not be taken, or teenagers or people less than 21 should not have access to these products. So it's not really about the legal status of the substances, but it's the more it's available, the more children and adolescents are going to be exposed. And you see that 85% of all the cases across the board, the reason for exposure was an intentional abuse. In this study, and as I mentioned, we're lucky with our collaboration that we are able to tighten within the UVA. We have the analytical testing capabilities that make us be able to test any urine sample, blood sample, or substance. Whenever we have this undifferentiated patient, they can't tell what they took, or they say what they took, it doesn't really fit the presentation. So we had a series of patients who said they got into a Amanita muscaria mushroom gummies, but the presentation did not fit what they said they took. So we said, all right, we have so many vape shops around us. Let's go on a shopping trip. We bought like 6, 7 products on different brands, and we sent them to the analytical lab. So you see what was listed as product ingredients, and this is what we found. The identified compounds, what we found. So we were really surprised to find Scheduled 1 controlled substance, psilocybin and psilocin, in these gummies. Of course, they were not labeled, but also these are Schedule 1 controlled substances. We were first surprised to see mitragynine, which is the kratom, and it's a substance that can lead to dependence, and other hallucinogenic substances. So during the same time we were testing this substance, there was an increased number on a national level of cases. And this is where America's Poison Center got involved with the CDC. And they did a nationwide investigation of human cases of people who got a poisoning taking these mushroom gummies. And so the CDC launched this national study looking at all the cases, the people who got poisoned taking the dimushroom, and they described what they took, the presentation, the level of care they received. And this led to a health alert network where people were warned to not take these substances, and the FDA had their warning, and also the products were recalled. This is the importance of informing the public, informing the key policymaker to be aware of these substances and make things change, like having these products recalled, making the public more aware that these products are not tested by the FDA, they are not regulated, they're not safe. So just to make more education to the public. Talking about our collaboration, I think the most important collaboration we have throughout the years is with the Virginia Department of Health. We constantly receive, and it is for several purposes, but one of the main purposes is when there is a change of legal status, change in decriminalization, in legislation. We get contacted by the Attorney General office, by legislature, if they need to know what cases are we seeing and what severity are we seeing, what are we seeing in the pediatric population. So they can ask about the trend in marijuana exposure in the adults, in the kids. We had a lot of interest, or VDH had a lot of interest in nicotine exposure in children. Again, the more the pouch, nicotine pouch are available, the more the children in the homes, the more the children are going to be exposed to these products. At some point, there was a certain area in Southwest Virginia that had a lot of cases of teenagers going to the emergency department for after taking a puff or two of THC, some kind of THC vaping. So they reach out and say, hey, do you see this increase? We're seeing some reports. So this is the collaboration we have with the Virginia Department of Health, and we keep them informed. Like now with the kratom and the 7-hydroxy, we're testing more samples and we're getting more results. So as with the mushroom gummies, we do let them know, hey, this is what we are seeing at our poison center. And one of our, I think this is where the future also is the analytical testing. Is not just saying, hey, we are seeing an increase, but also this is the result of the analytical testing or toxicological testing. Also, we are always in contact with our providers. We have a monthly newsletter for the providers, but also for general public. We like to go out and lecture. We have an educator that takes in charge of doing the educational material for the general public, but also our medical toxicologists go out and lecture the providers. We're happy to go and lecture in the hospitals, the 74 hospitals that we are covering. Talking also on collaboration, the importance of the Blue Ridge Poison Center being part of UVA is we have 12 schools, we have medicine, we have nursing, we have data science. With the importance of language models and data engineering, we had a great experience working with graduate students in master in data science and for their capstone project, giving them data, and they have usually a different look at the data, and we are always positively surprised by the trends they can detect. We've had amazing undergraduate students that are really motivated to work on literature review, but to try and draft their first paper. We have an undergrad who's going to go to the Wilderness Medicine Society. She drafted 2 abstract, and she's going to have 2 oral presentations. So it's a win-win situation where we'll have them build their CV and gain experience, but it's a lot of work that they can do, and they are happy to do it. We work with medical students, residents on research projects, and we're always happy to work and reconnect with fellows who graduated and went to practice in an area that is not associated in a hospital, not associated with a poison center. So they have great ideas. We can work together on more research project and putting out the value of the National Poison Data System. Reaching out to our regional poison center, I think this is going to be different from poison center to poison center. Chris, do you want to cover this? But I'm happy you have my email. I'm happy to, if you want to send me any email, you have any questions, I'm happy to be your
And
point
I'll
of
pop the
contact.
emails up in a second. I just kind of wanted to emphasize the importance of context that Rita really dove into here, that poison centers don't just have the data, they can also add clinical interpretation, exposure circumstances, and behavioral context that are oftentimes missing from larger data sets. So for those of you who are interested in using poison center data, your best first step is to reach out to your regional poison center, and I'm happy to connect you to your regional poison center if that's the route that you would like to take. Health departments can establish data sharing agreements. Those processes can take some time because of legal and governance requirements, but Researchers and institutions may also be able to license data sets for approved research and surveillance activities outside of a partnership with the Poison Center themselves. But just in general, it's important to build these relationships with your poison centers as long as your work can intersect with them, because beyond access to the data alone, their expertise and that contextual information is just really valuable. Poison centers, I think, are generally underused. If you looked at that spectrum of products on which we have data, I think that can kind of show you the breadth of the experience and context that is available by your poison center. So with that, I think Kristen already popped in the chat to please go ahead and unmute or put your questions in the chat. I just really appreciate the opportunity to chat with you today and hope that this discussion highlighted how poison center data can complement traditional injury data sets and your work specifically. So we're happy to take questions, and my email address is pretty easy. It's johnson@poisoncenters.org. So please feel free to reach out to me if you'd like to be connected with your poison center, or if you just have questions after this, I can also funnel them to Rita as well.
Oh my gosh. Chris and Rita, thank you so much for an amazing presentation. I see a question in the chat from Jason. How practical would it be to use data like these for near real-time or similar surveillance?
Thanks, Jason. So that's actually what we use it for on a daily basis. Now, if there's a health department, health departments typically have to have a relationship with their, really any entity has to have a relationship to have access to NPDS. If the data are licensed by a researcher or institution, then they would have access to NPDS and be able to see all of the real-time data. I will note that includes open and closed cases. Closed cases are those that have been followed to a no conclusion. Open are ones that still are not yet resolved. I think our clinical managing director was on here. Is she still? So Kate, if there's more that you would like to add around that, or if I missed anything, I welcome your input there.
No, sounds good to me, Chris.
And Anna, I saw that the poison center data is in your syndromic surveillance system. I know it's a little bit easier to do if there's like a state instance of Essence. I think it's a little bit more difficult for Biosense, is what I've heard in my CSTE calls. But
yeah, we actually have a homegrown syndromic surveillance system, NC Detect, and our poison center has been a partner for more than 20 years. And yeah, they are just excellent to work with. They have data that gives us insight to things that we don't get from our EMS or emergency department or urgent care data. Some examples, obviously you've got, the overdose piece, but we've also worked with them on snake bites and post hurricane things where you're looking at both some of the medication related exposures, but also those environmental exposures, the bites, stings, and venomations. So yeah, we are real believers in the Poison Center data for public health surveillance and make really good use of it, and consider them important partners in the work that we do.
Well, and the North Carolina Poison Center was actually one of 3 states, 5 poison centers that participated in a CDC-funded hurricane preparedness pilot. So
cool.
Yeah, so that it's really great to hear you say that about disaster aftermath, considering that's what I was hired on to take part in. So thank you for that. I'm going to share that feedback with them. I'm sure they'll appreciate it.
Great.
Oh, that's really interesting. We've been talking at Savor a lot about the intersection of natural disasters and climate change and injury. So it's interesting to see the data sets being used that way. And I look forward to hearing more about that as that develops. That's really fascinating.
Yeah, we have a hurricane related code that is co-coded with whatever the exposure was. So if it's carbon monoxide, gasoline, envenomation of some sort, that's how we flag that it's related to a hurricane. So that's been more frequently used in the last 2 years. But of course, last year we were lucky but unlucky not to have hurricanes to be able to kind of analyze those data. But we also have a wildfire smoke related code and winter storm.
That was my next question. If you do other natural disasters, so it's hurricane,
wildfire smoke, and then winter storm related, which of course we had a lot of winter storms earlier this year. So I'm actually going to be presenting on a bit of that data at the North American Congress of Clinical Toxicologists Conference, but I actually presented at the NACCHO Preparedness Summit on some of the hurricane preparedness work as well.
I think there have been some publications that have come out of work that was done post Hurricane Helene, where so many different agencies had to come together in that response, and looking at what people needed and how we were able to get those things to them. And I know the Poison Center in North Carolina was definitely a participant in that response. But you can probably find some actual published papers at this point from that.
Thank you.
I know when Chris and I first started talking about this method session, one of the big things here at SAVER is really ensuring that the next generation of injury and violence researchers are able to flourish and network and come together and have access to many things. And I know that you talked about this a little bit and Rita went through it, but working with students and access to data sets and just some of the intricacies of that as we see, students and trainees looking for access to reliable sets, either free or affordable or working with mentors. And I know that you talked about this a little bit, but could you just expand a bit more on going through that and how that can happen? I know, Rita, you mentioned that you've worked with students and that your system does. But I know that this is my understanding is like a federation that each state is collecting this data and bringing it to a national data set. So I just wasn't sure if you could just give a little bit more detail for some of our trainees on the line.
Yeah, so I mean, being part of 12 faculty schools, we got a lot of requests, more than people we can work or students we can work with. But we get a lot of requests for people, undergrads, graduates at every level, interested in doing research. Sometimes they would come like shadow with us for a week so we know them better. And they can give a presentation. This is how sometimes we build a relationship. And we give them sometimes for undergrads, a little project. And they do so well. We continue the collaboration. Sometimes there is the summer work summer students. We give them a task, and then this is a paid work. And this is how we build the relationship. And we teach them on the National Poison Data System. And sometimes there are pre-med students who wants to build their CVs. So we're happy also to help them building their CVs while giving them the experience of looking at the data, understanding the context of the data, understanding the trends, what has been an increase. And they are so good in researching the literature and trying to explain this increase, what changed in legislation, explain this increase or that. Also, like medical students, we have rotators. This is part of our fellowship program and the medical toxicology division. We have year-long 2 weeks to 4 weeks rotation with residents and medical students. And this is how they learn about the poison center data importance, the trends, the history of poisoning and toxicity, the change of legislation. They get a lot exposed to that during our daily teaching from 8 to 12. And usually they would come up, they say, hey, I'm interested in that topic. And we're happy to give them part of the data so we can train them on that. And so, yeah, we're happy to work with them. We're supervise them, giving them. Sometimes it's our poison center data. It's a clinical case with analytical testing, but also we use a lot with our trainee, the National Poison Data System, which is a great national data.
And I'll just add to that by saying that America's Poison Centers has recently started taking on interns as well. And the reason that we like to have the relationship is because the data do have limitations, and the context is very important. Like even knowing how to interpret a zip code is less straightforward than you would expect it to be, because the zip code is from where the case originates, not necessarily where the poisoning occurred. And so sometimes you see that there's a clustering around where there are medical centers, because healthcare providers will call or reach out to a poison center for help with case management. So we like to have a relationship built there. There's not typically, particularly for students and trainees, here's the data, good luck. It's always within the context of training and understanding the clinical context behind it.
Wonderful. And I know when we started talking about this and bringing SAVOR and America's Poison Centers together, it was with the fact that you have such rich data and that you've been building this out. And who are you hoping to have access to this, to open it up to make sure that people are aware of the data that's available, and how can we be supportive in that to make sure that everyone understands? I know when we started talking, I didn't realize how rich the data was. It's beyond just pills. It's a whole host, and learning about the intersection with climate change. Like, how can we help support making sure that everyone is aware of this amazing rich data set?
Yeah, I think what we really like for people to take away is that we're not just the drug people. We're not just for kids either. Those seem to be the two scenarios in which folks consider poison control. So we've been working in expanding into the preparedness space, obviously, through that hurricane preparedness work and expanding into the other disasters. But really, folks across the breadth of injury types for which we have relevant data, we would love to have the data analyzed, partner with folks, make sure that we're speaking to the right audiences. Because it's only been relatively recently that we've gotten to get in front of more of a public health, epidemiology type of audience. And we're getting into the injury space, we're getting into the pediatric space. So we're continuing to grow in that realm. So whatever opportunities you see available for us to just kind of be a voice, have a seat at the table, to make sure that we are able to contribute insights where they're useful, I think is really the direction that we're looking at going in.
Wonderful. I just have one more question. I know that you're partnering with Whiskers, and I know that Whiskers has been challenged. And I see Elizabeth has a question.
Just a comment. She said, thank you.
Oh,
Thank you.
okay. I was like, I saw her name pop up. So when you think about national, threats to some of these larger national data sets and these partnerships, what are you doing and thinking about in that space if there are challenges or there are disruptions? I know that your data, you've been coming up with innovation around using AI and creating supplements and making sure that you are creating a robustness. What are some of the other directions that you're taking in this current climate?
Actually want to punt this to Rita, just because I had a conversation with her director, Dr. Chris Holstig, about their students doing some work around comparing the data, the National Poison Data System, to other data sets. So hopefully, Rita, you don't hate me for passing this to you.
No, that was an interesting thing of comparing the CDC Wonder for cases of death by poisoning compared to the UCR, the FBI database. So it was an interesting to see. Sometimes it's hard to compare because it's not apples to apples. So the UCR have a way of collecting, and the classification of drugs involved and the context of the exposure is different from what the CDC Wonder. But we ended up finding somehow the same trends. But I think what the National Poison Data System has an opportunity is that it gives more details about the substances. And I feel, and Kate and Chris would be able probably to address that, where the National Poison Data System is going to provide more information on the substances and more granularity, and maybe at some point, that's my opinion, not throwing you under the bus, maybe at some point with how technology and things are moving, maybe we'll be able to say, to have a field like we tested the blood or urine and we found XYZ. For centers who have these capabilities, I think that might help us go to a new level. Did I answer your question or did I go tangent?
No, that was great. I mean, these are discussions that we've been having at Savor around data fidelity, working with partners, ensuring that science is able to continue. So I know that it's nice to see national partners thinking through
Yeah.
this
The
and having conversations.
NSDUH, the National Statistics on Drug Use and Health, have very interesting, and this is a database that is still available. We find a lot of interesting substance use trends in people aged 12 and up. And it's interesting to compare like with the National Poison Data System and other databases. I think it's a resource, it's full of resources database that kind of we can, from a substance use or injury, compare data.
Awesome, wonderful. Well, we are at time. That was amazingly timed. Thank you both so much. Thank you to America's Poison Centers and to Dr. Chris Johnson O'Leary and Dr. Rita Farah for taking time today to join us in a wonderful conversation. We'll make sure that we are sharing this out with our members and our trainees because it is this amazingly robust resource that I think we can make sure is being accessed and made aware of. So thank you so much for your time today at Savor's Method Session. Please be sure to visit our website at thesavor.org, and we hope to see all of you soon. Thank you for your time today, everyone.
Thank you.
Thank you.